My first, I guess, knowledge of SIDM was when I was patient safety officer at the Joint Commission and had several calls with Paul Ebner and Mark Graber at that time. And the effort that they were pursuing with the Joint Commission was whether or not diagnostic error should be a part of the Joint Commission's process around development of standards and survey methods to see if organizations that were accredited were in fact addressing a diagnostic error in medicine. And then I guess back in 2018, I met with Paul at that time and was asked if I would consider joining the board of SIDM. And I immediately said yes, I certainly would, because I'm an internist and have a career that's splattered with patients who've been harmed by diagnostic error. So that was my introduction to the board, and quite frankly, just a stellar group of people that serve on that board or who had served on the board in the past, whose paths I've crossed or worked with in previous collaboratives and other activities around patient safety. So, I do really global work in healthcare disparity, and I think it's important to understand what we mean by disparity and how there is I guess, convergence of diagnostic error and disparity. And to be quite blunt about it, I guess, diagnostic error and disparity began, I'm just going to say in 1619. And one example of that was even during slavery, there was a diagnosis given to African slaves that was called drapetomania. That's a diagnosis. Drapetomania means that if a slave ran away, they had some mental disorder. So that is a misdiagnosis, obviously, and the most egregious kind of misdiagnosis or diagnostic error. And then we can go through history and talk about the diagnoses that have been given to Black, brown, and indigenous populations that have led to harm, injury, and death. So I think it's all too appropriate, particularly at this time that SIDM begins to address diagnostic error and disparity, and quite frankly, health inequity. And I think a lot of that has converged around social justice issues that are happening right now. Black Lives Matter, not just the George Floyd murder, but the over-policing of Black and brown communities for generations. So I believe it's all too appropriate. Additionally, there is an effort to address long-held beliefs in diagnostics that there should be some difference in how we approach a diagnosis, whether it be osteoporosis or whether it be diabetes or sickle cell or pain treatment or even kidney disease, that are based on algorithms that are inherently racist. So I think at multiple levels, and I'll start at the highest level, they have been institutionalized. So there's something called institutional bias, and again, quite bluntly, what I'm saying there is that's institutional racism that impacts how diagnoses are made, and then how that's linked to clinical decision making. They become structural inside of organizations and practices, and they become part of the norm of an organization. They become a part of the values of an organization, and again, they lead to preventable injury, harm, and death. And then there is what we would call personally mediated bias, and that again goes back to both implicit and explicit bias that can be rooted in how caregivers make diagnosis, and then how they guide treatments that can do further injury based on a faulty diagnosis that's rooted in personal bias. The unfortunate thing there then is that many populations, particularly Black and brown populations, internalize that bias and begin to believe it. So one example is that as a patient I had as a diabetic who came in for the first visit, who was uncontrolled type 2 diabetic, 48-year-old Black female. And when I said that we can get your diabetes type 2 under control, she started to cry. And when I asked her why was she crying, she had been managed by a white endocrinologist who just by happenstance taught me in medical school. He had told her that her type 2 diabetes would never be controlled. And I think that is just the epitome of a misdiagnosis. So just the idea that her diabetes could come under control was too much for her to bear. So she had internalized, and many people do, particularly Black and brown people, have internalized that I can never be as healthy as I want to be. I can never overcome these medical conditions because there's someone that I go to see that I should trust who tells me my blood pressure is never going to be controlled, that my pain will never be controlled, that my glucose will never be controlled, that a sickle cell pain of 8 is acceptable. So all of that plays into how we diagnose and make clinical decisions. So there's a spectrum then of bias from institutional to structural to personal to internalized. I get that question a lot, and usually I start to answer this way. We have become ahistorical, and that is why I began with 1619, but I go back beyond that to 1492. And that was when the Spanish explorers landed in what was then called Hispaniola. The result of that landing was 600,000 indigenous people died, which I would equate to genocide. They were replaced by African slaves who were brought in to work in the sugarcane plantations. So then when we just think about the beginning of the transatlantic slave trade, that is the epitome of social distancing. That is the epitome of what happened as it relates to disparity subsequent to the transatlantic slave trade. And then when we move forward through history, then I would say that the canary in the coal mine as it relates to healthcare delivery for Black and brown people was already on life support before COVID hit. And all those years of disparity in treatment and equities in treatment led to the near death of a canary in the coal mine. And we look at the data, that's life expectancy, that's complication rates, it's readmissions, it's clinical outcomes, it's patient safety, it's the patient experience, and it's the effectiveness of care that existed pre-COVID. We also knew then pre-COVID that there were populations of people in this country that had not just been devalued, they had been dehumanized. The next thing then that we knew about that was a canary in the coal mine before COVID was there was already a resource allocation of people, supplies, equipment that was unequal before COVID. Those are known knowns. So then I say to people, why would you be surprised that the death rates for Black and brown people, indigenous people, people in long-term care facilities, people who are incarcerated, why are we now somehow surprised that COVID caused this? COVID did not cause it. It was a pre-existing set of conditions that was exposed by COVID. So now as we rush to say, well, COVID has something to do with this, COVID is just the next thing that happened. We can go back through history again to multiple outbreaks and catastrophes that impacted primarily and unequally Black and brown people. So COVID is just the latest. So my hope then is that we look at this and say, we need to understand the history that led us to this point. We need to understand how we need to value all people, not just people that have insurance or people that have white skin. And we also need to recognize that there are low-income populations, Black and brown populations across this country that were under-resourced before COVID. So this is the opportunity we have now in all phases of healthcare delivery to address the gaps that existed prior to COVID. I think that the nice thing about this conference is we've tried to address a spectrum of disparity. So in this year's conference, I do think we're bringing together some of the country's leading experts in different areas across the spectrum of disparity. So it will be racial disparities. It will be what people who are obese experience and what we now call sizeism. We will discuss ageism. There are people who long been treated differently because they have what was previously known as the chronic fatigue syndrome, and now the overlap between chronic fatigue and what we call long haul COVID. So we'll have an expert there to talk about long haul COVID and the difference in the ways people are treated with long haul COVID. We hope to be able to have sessions around what we call ableism, whether that be physical or cognitive disabilities. So I think that the advantage to people who attend will be that you will see a spectrum of terrific presenters who will discuss disparities and all of the so-called isms that continue to exist in health and healthcare. What I'm looking for most too is having people feel uncomfortable, and to begin to be comfortable with that discomfort, and then go out and do something about it. So if people can take away some ideas about what their strategies should look like when they begin to address healthcare disparities and inequities primarily, then they can go back and put in place some actions that are sustainable. I think people should come with open mindsets, and again, begin to think about and decide how to act on issues that have persisted for hundreds of years. So I hope that something in this conference will spark people to go back and say, you know, I need to understand more about the history of my organization and the role that my organization has played in historical disparities. We need to understand more about how we can bring more value and trust, quite frankly, to the population that we serve. We need to go back as leadership, whether it's in communities or in healthcare organizations, and say, are we in fact resourcing communities and our organizations in a fair and equitable way, or has there been unequal resource allocation that we need to correct? So I hope that somewhere in there, different types of people, different types of organizations will hear some of this and say, what are we doing in our organization? How does disparity operate in our organization? And from a patient safety perspective, why is it operating? What are the root causes? And then how do we put in place, again, sustainable corrective actions?